All right, school-based programs to reduce alcohol and drug use. There's a lot of different options, but the first question we're going to tackle is how do we evaluate these things to make sure that they actually work? So first we need to pick an intervention. Now, I'm going to give a couple examples of what's been used in the past, but those are just kind of general guidelines. Really, if you're interested in school-based programs, you have to go into the literature, find the programs that work before you decide on one. So you pick your intervention, whatever it's going to be, and then you have to choose your outcome. What do you want to change? Do you want to change any substance use? So you use a survey like the ASSIST, where you're measuring alcohol and tobacco use and marijuana and opioids, and you don't care what's being changed, you just want to change the behaviors in general. Do you want to change a specific outcome in terms of a specific substance use? So you want to decrease smoking, you want to decrease alcohol use, you want to decrease marijuana use, and you don't care about all the substances out there? Are you going for more of a harm reduction approach? So do you want to reduce the frequency of use, or do you want to reduce the quantity of use? So you have to decide this before you even really implement the program. You need to figure out what is the main outcome that you want to measure. Where do you want to see change? It's very important, but often an underappreciated question. And then, since this is a school-based program, you got to find a school that has typically a bunch of classrooms in it. This is the School for Experimenting on Children that I've been in close touch with over the years. Of course, it's obviously a real school. Why would I create a fake school for a course such as this? So once you find a school, you're going to typically deliver the intervention in the classroom itself. You're not going to do it one-on-one. You're not going to do it in a big auditorium in front of all the students all at once. It's simply impractical. You have to work within the bounds of what the school is going to give you. You may have, if it's middle or high school, you may only have like one class period, which can be 45 minutes, or it can be longer. Maybe you only have homeroom, or the start of the day, and even down elementary schools where you have only 5 or 10 minutes, and that's the only time you'll be able to have with the students. So you really do the intervention to whole classrooms at the same time. And what this does is that it means that all the students are exposed to the intervention simultaneously. It's not given on an individual level, and it's given at this small group level. Now, ideally, the classrooms you expose to the intervention would be selected at random. And this can be done pretty easily. On top of that, the participating schools would also be selected at random, although this doesn't occur quite as often. You may have a randomly selected list of schools, but in the end you need principals to sign off on it. You may need superintendents of whole school districts to sign off on the research study. So you kind of end up getting this this congregation of schools in tight geographic areas. So maybe it's all the schools in a school district, or maybe it's one school you pick particularly because it's in a rural location, and you pick another school particularly because it's in an urban location, so you can kind of compare the two differences. But so the schools themselves may not be randomly selected, but the classrooms within the schools should be randomly selected for those both being part of the study as well as those being exposed to the intervention. And then what you do is you simply compare classrooms that had the intervention to classrooms that didn't have the intervention, which these classrooms that didn't have the intervention act as your controls. Now, the pros of this method, the pros of using a school-based study, is that you're delivering an intervention to a large number of people simultaneously. Yes, it's classroom by classroom, but you're still talking 10, 20, 30 students at a time, and if you can do multiple classrooms in a day, you can easily encounter hundreds of students in a very small time window. But there's a couple cons. The ones up on the PowerPoint slide really have to do with analyzing the data and being able to detect differences based on your program. And what it has to do is the level of randomization. Because you're randomizing at the classroom level, you really can only detect differences between classrooms in the intervention and control groups. So rather than having a few dozen or a few hundred people in the control condition and in your intervention groups who are actually receiving the program, you may only have 5, 6, 8, 10 classrooms in each condition. So now your sample size, when you analyze it using the appropriate statistical tools, which we will not get into here because it's relatively, it's moderate level to advanced level to do so, you really only have a sample size of 10 in each group rather than 100. So it's something to keep in mind when you're doing a school-based program and you're evaluating the outcomes of a school-based program. The other con of this technique, which is not on here, is that you're not including people who aren't in school. And that's actually a big deal because the students who are missing school often or are not in school at all or who have dropped out of school are likely at the highest risk of developing an alcohol or substance use problem. So while your program may be effective and the statistics come out saying that it's effective, you may not actually be able to reach the people that are most at need for the program. Again, something to keep in mind when doing and developing a school-based program. All right, so here's the brief history, and I emphasize the word brief history, of the types of school-based programs that have been implemented. One is in kind of the classic example, or one of the classic examples, is simply telling people the dangers of drug use. This is, well, this image is a much older one than when I was in high school, and I don't know how many high school students or middle school students would be particularly turned off by this flyer, but the dangers of drug use was essentially my health class in high school. It wasn't how to combat it, or it wasn't like how to say no of it. It was just like, this is a really bad thing and we need to not do it. As part of this, instead of using scare tactics, which is kind of what the dangers of drug use is, some programs simply provide objective information. Here's how many people use. Here's how many people are addicted. Here's how many people die from use. So with heroin, for instance, here's how many heroin overdoses have occurred in the country in the last 12 months. So very objective without putting emotional spin on it positively or negatively. There are programs that focus on the student, even though it's a classroom environment, that focus on someone's self-esteem. So if it's kind of a way to train people to be confident in their decisions, so that if they're approached and are asked to use a substance that they don't want to do, that they're not pressured, and they have the self-confidence and the self-esteem to say, no, I'm okay, I don't need to do this substance at the moment. The DARE program was part of the resistance training movement, so it attempted to get people to say no to drugs in a different way. It wasn't the self-esteem pathway. It was a different type of training, and the DARE program in particular is both the best example of this, but also one of the better examples of something that simply didn't work. And then a lot of programs use social norm campaigns. And what this is basically teaching people that the normative behavior in their community is a lot different than what they think. So in a college setting, the average college person actually drinks a lot less than how much you might think they drink. Or they use drugs, they use marijuana, they use opioids, they use cocaine a lot less than you might think they do. Essentially, the person that you think, they're not quite as cool as you thought they might be. So you don't need to feel pressured into using that much because people don't use that much to begin with. So when you're talking about school-based programs, they all have a common theme. They are all directed at the individual. Even if they're given in a group setting, they're still directed at the individual, and they're all based on individual behavior change. There's no policy implications, there's no environmental change. It's really based on the individual doing things different. So the resistance trainings are, in the self-esteem training, is about the individual being able to say no to a drug, and the individual having the confidence to say no to a drug. The social norm campaigns are about the individual realizing that, well, the average person doesn't drink as much as I thought they did, so I don't have to drink as much as I thought they did. The health education, the just straightforward health education, is about an individual seeing that information and hopefully making a decision we would want them to. But again, they're missing out on all of this environmental focus on the context of use and the policy environment of use. In general, what these programs come back with is that there are statistically significant benefits. The intervention groups do tend to use substances, whatever you're measuring, however you're measuring it, at a less rate than the control groups. but practically speaking, there's very few benefits. So you may have a quarter of a drink less in the intervention group, or a few, enough people in the intervention group don't use marijuana quite as often as in the control group. But practically speaking, there's really not many significant benefits. You have more benefits when it comes to school environment programs. So instead of focusing on the individual and individual behavior change, you can promote a favorable environment by not even focusing on addictive behaviors in general. You just say, you basically promote healthy activities and you reward positive actions. So at a very young age, that's what the good behavior game is. You're not saying don't do drugs, you're saying we're going to give you a present, we're going to give you a prize if you do something good in the classroom. If you're a good listener, if you help out your classmates, if you turn in, things in on time. We're going to promote that good behavior, and we're not going to talk about all the bad things we don't want you to do. And the idea is that by promoting healthy activities, by promoting these good behaviors, people will do that instinctually, rather than kind of have to be convinced to do it when they're on their own. And then finally, let's talk about college programs, because pretty much every college student, at least here in the United States, has to go through, at least an anti-alcohol campaign, or a moderate alcohol consumption campaign before even arriving on campus. They typically rely on just straight health information or social norms programs, but there's really no evidence that these programs, in particular for alcohol, have any effect. And as an aside, a lot of these programs, such as Alcohol 101, have been developed by the alcohol companies themselves. So there's a bit of conflict of interest involved when the entity selling the product is coming up with the program designed to get people to stop using the product. Now, there is some research saying that these information campaigns and these social norm campaigns can be effective if they're combined with something like a brief intervention or a personalized treatment, but even these effects are very short-lived. You're talking weeks, maybe months, but they definitely don't go into the effects definitely don't stretch out into the years.